Hello, my name is Shane, and I've had ulcerative colitis since 2012. Over the years, I've been on several different treatments. I've been on different steroids, some that affect the whole body, some that affect just the stomach. I've been on mesalamine as an enema and also as a pill. I've been on 2 different infusions, first infliximab, which is a TNF medication, and then the current medication I'm on, vedolizumab, which is a monoclonal antibody. And I've also been on azathioprine, which is a systemic immunosuppressant. And it was hard for me to get a good gauge of what is working, because at first I just thought, as long as I'm not bleeding, it must be working. But then I learned it's more than that. I can want and I should get control of all of my symptoms, whether that's urgency, frequency, or even just the consistency of my bowel movements. And it took some pushing from my family to be more of an advocate for myself, but now I feel that I'm able to talk a lot with my doctor to make sure that I feel like things are going well. Understanding my clinical management, the terms they use, and the outcomes has been a little bit different for me as a member of the healthcare community, just because I have an understanding of pathologically what's happening. It's just part of what I was trained on. But it was different because now I had to think about how this was going to affect my body, and that was completely different. So that's where talking to my healthcare provider was important. And it's really important to stop them if they're using words that confuse you or that you don't understand, because sometimes doctors forget that there are words that they use every day that everybody else doesn't know that well. And I also looked out and that I've had a lot of friends that I can talk to about this. And it was something I was hesitant about at first, but I found talking to friends helps. I found that one of my best friends also has the diagnosis, so they've been a really great confidant for me. And then just talking to other people, whether they have chronic diseases or they're healthy, just people, can be helpful because they can all provide some insight and shine light on things that I might have normalized that I should probably address. The blessing and curse of this diagnosis is that there are so many treatment options, and there's research, so there's more that's bound to come. The older medications work well, but they have a lot of side effects. The newer medications are more targeted, so they have fewer side effects. And knowing where to start really depends on your treatment team. Based on how you present and your symptoms, they're going to decide where you should start, but you can still be an advocate. I didn't want to start on any of those older medications because I was worried about their side effects. And also, when you need to make changes, part of that is your symptoms, but part of it's how your colonoscopy looks. There was a time when I was asymptomatic and I thought I was in remission, but then I had a colonoscopy which showed my disease was not well controlled, so we had to make a change. Now that I've been in remission for a few years, I'm very nervous about making any changes to my treatment, to be quite honest. And I know there are new medications that might make things more convenient or easy for me, but I know what I have works. So I'll talk to my treatment team, and if my doctor really feels like this is a better option for me, I would consider making that change, although I'd need to be sure that I'm okay switching back if it doesn't work out.
Shane talks about the evolution and promise of therapy for inflammatory bowel disease. We're in a very exciting time where every year we have at least one new therapy for inflammatory bowel disease. Back in 1998, when the first monoclonal antibody, infliximab, was released, it was the only one. Now there's over a dozen new therapies for Crohn's disease, and we need to find the right one for you. In inflammatory bowel disease, providers are aiming for something called treat to target, which means that we have a goal or a target and we're trying to treat to achieve that. This requires shared patient decision-making to make sure that you're on board with the therapies as well as with the target. We like to treat disease aggressively up front because if we can get things under control early in your disease course, you have a much better long-term outcome. And this means completely healing the lining of your colon, avoiding surgery, and not having to live your life around your symptoms. This is not always possible for everyone, but it is a goal. If you're not there, it may be time to start a new therapy. If you still have active inflammation, there may be better options. These are things that you can talk to with your healthcare provider and review on reliable websites including Crohn's Colitis Foundation, to look at what new therapies are out there and what may be right for you. The fear of changing therapy and side effects of therapy shouldn't hold you back. Most of the therapies that are available for inflammatory bowel disease are very well tolerated, and the risks of the disease itself need to be weighed against the risks of the medication. For example, there's a 1 in 1,000 risk of lymphoma with anti-TNF agents like infliximab, adalimumab, golimumab, etc. However, the risk of colon cancer in somebody who's had colitis, either Crohn's colitis or ulcerative colitis, after 20 years of disease is about 1 in 5 or 20%. And you can reduce that risk by reducing inflammation. So it's important to look at the whole picture and to make sure that you are on the best therapy for you, for your disease, and that you and your provider agree on what the target of your therapy is.